Great. Thank you all for participating this morning uh, on a Friday morning, before next week's conference. Really excited to hopefully see many of you in person. I will be there uh, with an exhibitors table. I was there last year. Really just a great conference that AFF-CNY puts on. I have been a fan of AFF-CNY for a long time. I used to be the associate director of the New York State Kinship Navigator. And in that role, I did a lot of policy and advocacy work in the space of child welfare, specifically around kinship care. I've got a lot of experience in dealing with kinship foster care. I did a lot of foster parent trainings in Onondaga County, where I hail from originally. I now live in Albany. But for kin gap training, I did a lot of foster parent training, kin gap. Back when I was doing that job, I moved from there to the Office of Mental Health, where I worked in the children's division for the Office of Mental Health for 2 years, and now I'm in year two of working for the New York State Council for Community Behavioral Health Care. We are an association. We represent 160 community-based organizations that deal with mental health and substance use disorder treatment in the public space. So, a lot of Medicaid providers. As my role in the council, we call ourselves the New York State Council. My role in the council is the CHAMP project specialist. CHAMP is the Community Health Access to Addiction and Mental Health Care project. It is a joint project between the Office of Mental Health and OASIS, the Addiction and Substance Use Services. We are the statewide ombuds program that I'm going to be talking a little bit more about. But what an ombuds program is we help folks on the ground who are experiencing barriers, specifically health insurance barriers, when they're trying to access mental health or substance use disorder services. And so, the ombuds program that I'm a part of now, we are folks kind of first line of defense. We're a free service. Again, I'm going to talk more about it later, but we are the first line of defense when health insurance is the barrier to accessing needed services in mental health and substance use disorder. And we deal with the whole spectrum of ages, youth through adults, and not just folks in child welfare or experiencing child welfare interventions, but across everybody, anywhere, anytime. And so today's presentation, I'm going to be talking about the youth mental health crisis here in New York State, in America at large, and then zeroing in a little bit on foster care and youth in foster care as well. There's been a lot of research and a lot of attention being drawn to the fact that, and I'll keep it to New York, but that New York's youth are experiencing mental health symptoms, conditions, substance use disorder at skyrocketing rates. I think it's really important that we as a people, A, know that that is happening, and B, know what some of the causes are behind them. And then thirdly, I said A, B, and thirdly, but I think you get the idea. Thirdly, what can we do about it? And so, we're going to talk a little bit about the youth mental health crisis to set up the fact that, okay, what can we do about it? Access to care, right? There are agencies out there that provide care to folks who are experiencing behavioral health symptoms. And when I say behavioral health, that term, I'm just lumping in mental health and substance use disorder. Behavioral health is kind of both of those things in the same term. And so access to care, presumably would be the solution. Like, let's increase the number of providers, let's make it less expensive, let's decrease wait times, things like that. But I'm going to talk about some of the barriers to accessing care in today's presentation. Specifically, I'm going to talk about health insurance as the barrier to accessing needed care. So again, CHAMP, the organization I'm working with, this is what we do full time, is we deal with what are health insurance plans doing that is creating a barrier for the care recipient or the consumer who's looking to receive mental health services or substance use disorder services. What is their health insurance plan doing that is causing them to not be able to get access to that? You probably won't be surprised to learn that there are a lot of things that your health insurance is doing to try to prevent you from getting care. So I'll be talking through a number of those different barriers. Then under policy and action, I'm going to talk a little bit about CHAMP, the program that I'm working with, and what we do. Everything that we do is state funded and free of charge to everybody who calls us. I gave this same presentation at the NAMI conference in November of 2024. NAMI is the National Alliance for Mental Illness. And after I gave the presentation, I had multiple people come up to me at the end and go, wow, I really wish I knew about your program because I paid tens of thousands of dollars for a lawyer who probably did the same thing that CHAMP would have done for me. So, CHAMP as a free and accessible resource to everybody is something that I hope you take away from today's presentation. So let's dive right into the youth mental health crisis. So the Surgeon General under the Biden administration released a report indicating that 1 in 5 youth are reported to have a mental, emotional, developmental, or behavioral disorder. So setting a baseline to understanding the phenomenon, we've got a 34% increase in youth in New York who felt sad or hopeless for a 2-week stretch of time or longer since 2011. So if you were to graph that on a chart, that number's going straight up. The way that we determine whether or not someone is experiencing significant mental health, because obviously youth generally, set aside foster youth for a second, youth in general go through lots of emotional waves, right? So there's stuff that happens at school, there's stuff that happens at home. And so they might feel sad, they might feel depressed for short amounts of time. But research generally looks at feeling sad or hopeless, those symptoms of depression that last for continually for 2 weeks or longer is usually a sign of something more significant than your typical adolescent or teenage emotional imbalance, we'll put it. So seeing a large increase in those folks who felt sad or hopeless for 2 weeks since 2011. We have 1 in 4 New York youth who have experienced a behavioral health condition in 2022. That's 25% of the general population. I'm going to compare it to the foster care population in a second, but about 25% of the population experience. And again, when I say behavioral health, I just want to define for you that that's either a mental health condition or a substance use disorder. We've seen a 9% increase in major depressive episodes since 2010, a 57% increase in suicide rates of youth ages 10 to 24 between 2007 and 2018. And we've seen a 28% increase in psychiatric visits to the emergency room between 2011 and 2015. So even some of this data is even 10 years old. Ultimately, the number has continued to rise. And I think that is a cause for concern, generally speaking. Like I mentioned, under the Biden administration, the Surgeon General released a report basically saying we're in the midst of the most significant youth mental health crisis to date. We can no longer ignore that youth are going through something and they're needing assistance. So youth in foster care, 80% of youth in foster care experience significant mental health or behavioral health challenges, which is obviously significantly higher than the 1 in 4 that I mentioned on the previous slide. So you all know many children in foster care have been exposed to trauma, abuse, neglect. And then youth in foster care also experience higher rates of substance use disorders, but that usually occurs later in life compared to the general population. So the experiences that they've had in their youth often lead to a higher rate of substance use disorder this bears itself out in a lot of the adverse childhood experiences data that I'm sure many of you have seen and heard about previously as well. So for those who are entering foster care, these are just your typical mental health diagnoses. If you're a foster parent, you have probably seen multiple of these things in the youth that have been residing with you. But, as a kinship advocate for 7 years, this is, pretty typical of children who were in the care of relatives during that time. So one of the things that I took out of this presentation that maybe I should have left in, that I think is an important piece to point out now, and of course, now that I'm like giving the presentation and talking about a slide that's not in here, everyone's going to go, okay, great job, Ryan. But, the New York State budget season is upon us. Normally, New York State passes its budget on April 1st, or at least they try to, and obviously it's May 2nd. We haven't passed the budget yet. But one of the sticking points in the budget has been that the governor introduced a bell-to-bell ban on cell phones and internet connected screens in schools. And that has been a sticking point in the legislature. The schools, they want a little bit more control over how they handle that and don't want a mandate from the governor. There's obviously political things going on about that. But I recently personally read the book Anxious Generation by Jonathan Haidt and would highly recommend it. I had a couple of slides in here. Again, I took out for time constraint purposes, but that pointed to, a major cause of the upward tick in mental health issues, especially issues as it relates to how youth view themselves, how they interact with their peers, had to do with social media and the use of cell phones for youth at a young age. And so again, I'll just put a pin in it since I took the slides out to devote to this, but I think it's important to note that even in the Surgeon General's report, social media, Facebook, Instagram, TikTok, Snapchat, and cell phone usage generally has been correlated to the rise in mental health issues, especially in young girls. But young men too are experiencing a lot of increase in mental health, and the suicide attempts within the young male population has skyrocketed as well. So obviously we have issues. I could have done an entire presentation just on addressing youth mental health crisis, but I think it's important to remember that, hey, we've got a whole system here in New York State and across the country set up to help people who are experiencing behavioral health problems. And so access to care is an important piece in getting people the services they need. So are youth accessing care? Let's talk about it. 42% of youth did not receive the care they needed for behavioral health in 2022. That's a pretty large number. Almost half of the youth who needed care, not even those who aren't identifying as needing care. So some youth may have identified as, I was sad or hopeless for 2 weeks or longer, and be lumped into that group of folks who, they probably need additional assistance, but then they didn't identify that they needed care. So this is just 42% of those who identified the need for care didn't get it. 90% of individuals who have a substance use disorder don't seek treatment. This is just true nationally. That number is way too high. There's a plethora of reasons that's because of. Stigma, I think, is one of my things here in 2 slides, so I'll refer to it there. The time span, and this data comes from the Surgeon General's report, the time span between the onset of a mental health symptom and actually getting treatment is 11 years. So if a youth starts experiencing a mental health symptom when they're 10, they probably aren't going to get the assistance that they need to address that mental health condition until they're 21. Meanwhile, they're going through life. They're experiencing all kinds of developmental milestones while also carrying the burden of a mental health symptom, substance use disorder symptom. And so we need to shrink that time span for youth who are experiencing mental health and substance use. Stigma is a big barrier to accessing care on multiple levels, but from a care recipient level, societal views and attitudes towards mental health impact help seeking. If I'm not strong enough, to handle this type of thing, then I won't be strong enough to handle the next hurdle in my life. And so I'm just not going to talk about it because I'm going to get through it by myself. This keeps people from accessing or going to get the care that they need, which is why you see campaigns all the time on TV, on social media, all over the place, that it's okay to get help. If you're experiencing an issue, it's okay to ask for help. If you're a sports fan and you watch sports, they do mental health awareness. May is Mental Health Awareness Month. A lot of players will come out and talk about their own mental health battles. I mentioned earlier that I'm a big Mets fan, and I just saw this morning Francisco Lindor, who finished second in MVP voting last year, shortstop for the Mets, had a 2-minute little thing on Instagram about how he deals with his own mental health during the course of a long season. So again, it's important to put the message out there so that people, especially young people, see role models who are reducing the stigma around accessing and getting help. So 97% of youth in New York State are enrolled in health insurance. And so sometimes people might think, well, people aren't accessing care because they can't afford it, right? Like they're not going to a counselor because they can't afford $100 a session or $200 a session. And so they're not going because they can't afford it. But if youth have health insurance, the idea is that the health insurance is going to pay for it, especially if it's Medicaid. So most, if not all, foster youth are enrolled in Medicaid, have managed care. And, so presumably then they should have access to the services that they need within mental health or substance use disorder, based on the fact that it's not affordability that's the issue. So the reason I have this in there is to say, like, as a state, we are one of the highest states for enrollment in health insurance in the whole country. We have over 7 million people enrolled in Medicaid in New York State, and an additional 2 million people enrolled in the Essential Plan, which is basically Medicaid, but for people at a higher income level. So roughly 9 million people on publicly funded insurance programs in a state where, we're about 18, 19 million people strong. So, 30, 33, 30, a large percentage of New Yorkers are enrolled in public insurance. Again, that being said, it's not that folks can't, it's not that the insurance, access to insurance is not the issue that folks are experiencing in terms of accessing care. So for youth in foster care, ideally mental health services are going to be provided by well-trained mental health professionals who can provide care that's continuous over time in the context of the culture of foster care. But obviously, not every community has a dearth of mental health professionals, and they may not have access to them in a timely manner. This is true just across the board. I gave a presentation in Fort Edward on Monday of this week, which is Washington County. And, one of the first questions that I got from them was, what can you do about wait lists? We've got people who are waiting to see their therapist for 3 months. Their therapist just can't see them for 3 months. what can you do about that? And, you know, we're going to talk about why that is in a few slides. So I'll have you put that in your back pocket. But having access to a mental health professional or a substance use disorder professional in a timely manner actually is a health insurance plan problem. We're going to talk more about that in a little bit. Obviously, discontinuity in mental health care can result as a transition in placement, lack of consent, health insurance barriers. So some of these issues need to be solved at the systemic level, which we're going to talk about during our policy portion of this presentation. But certainly, you know, while a youth is in foster care, they are supposed to have access to mental health services. They're supposed to have wraparound care. There should be all kinds of services in place, but there still remain barriers in terms of timeliness. And then once a youth comes out of foster care, whether that's they've returned to their biological parent, or they've been adopted or moved to a custodial relationship or a guardianship relationship, continuity of care once that permanency goal has been met certainly becomes a huge issue moving forward. So let's explore why health insurance is one of the primary barriers to accessing care. It's kind of counterintuitive, but the reality is the health insurance system that we have set up in this country provides usually more of a barrier, especially as it relates to accessing behavioral health care. That is so much so that we have laws both on the federal and the state level, including regulations that have been promulgated by state agencies that are intended to enforce parity. We're going to talk more about parity in a little bit, but one of the biggest things that CHAMP, the organization I work with, deals with are parity violations from health insurance companies. So they're not providing access to behavioral health care at the same level that they provide access to physical care. Primary care physicians or surgeons, medical, surgical. And so we've had to write whole laws about it because behavioral health care, mental health and substance use disorder is not a money-making endeavor for health insurance plans, but health insurance plans are for profit. Even on the Medicaid side, managed care plans are trying to cut a profit. So let's talk about it. Told you I'm in my second year of this work, and the longer that I've been doing this work, the more jaded I think I've become towards the system that we have in place. You know, if you hear a sense of snarkiness from my voice, it's because it's just been beat down. But hey, we're all dealing with broken systems and trying to reform them and make them better. So that's what I like about the coalition and everything that AFF-CNY does in trying to transform the child welfare system too. So let's talk about how health insurance is pulling its best Gandalf here and not letting folks through. A little Lord of the Rings reference there for those who aren't familiar. So what are the common barriers that we see health insurance plans creating for folks as they're trying to access behavioral health? Network inadequacy. I'm going to go into each of these ones more in depth, so I'm just giving you an overview here. Network inadequacy, not providing access to in-network providers and services. In-network meaning that your health insurance plan is going to pay the provider on your behalf. Usually you're only responsible for a copay. So if you have an inadequate network, there's not enough people near where you live to adequately provide the services that you need, that your health insurance will pay for. Low and late reimbursement. So this is specifically around providers, but payments to providers below the cost it is to provide the services, right? So in behavioral health, you have professionals who went to school for a long time, just like doctors who go to school for a long time and get tons of clinical hours. And it's not inexpensive to be a licensed clinical social worker or a licensed mental health counselor, or anybody who's providing services has gone through a lot of training and education to be able to provide those services. It's not inexpensive, but health insurance plans notoriously undervalue the services that are being provided in the behavioral health space. And so they negotiate or refuse to pay reasonable services. And that, as a result, we see a lot of folks unwilling to participate in network with health insurance plans. parity violations. Again, unequal services being covered by the health insurance plan when it compares to medical or surgical services being provided by the health plan. Again, we're going to dive further into that in a minute. Step therapy. If your therapist has prescribed you a specific prescription drug and your health insurance plan won't cover it because it's not a generic brand or because it's not the cheapest one, that's a problem. And so they want you to fail on the cheapest version first before you get access to the prescription drug that your provider has prescribed. We'll talk more about that. And then non-qualitative treatment limitations. This speaks for itself. This is just the practice. We call them NQTLs. We want to limit the amount of treatment folks have access to. And this is just how health insurance plans operate, both on the medical and surgical side and on the behavioral health side. But it limits the scope or duration of benefits for folks who are getting services. So let's talk more about network adequacy. So in theory, a comprehensive network, which is being prescribed by state and federal law, would require that a health plan maintains an accurate provider directory. Hey, I need to find a provider, a mental health practitioner. So, the best way to do that, I suppose you could Google. You could say, licensed mental health counselor in my area, and then call that mental health counselor and say, I've got Aetna insurance. Do you take that? Okay, you don't take that. Okay, thanks very much. And then call the next one on Google. Or what a lot of people do, and what probably you should do, is you go to your health insurance's website. I've got Aetna insurance. Okay, let me go to my Aetna website and see what licensed mental health counselor is available in network so that I'm not paying out of pocket, that my health insurance is going to pay for it. Let me call that provider. So in theory, your health plan would maintain an accurate provider directory so that when you call them and say, I need a licensed mental health counselor, they could give you a list of mental health counselors who are in network with them. This is like, I'm way over explaining it, but you'll see in just 2 seconds, why this doesn't make sense. Also, would, state and federal law require that they maintain adequate, not just accurate, but adequate provider networks and comply with mental health parity rules. So mental health parity rules on the federal level indicate that if you have 100 primary care physicians that you have in network in your health insurance plan, you need to have 100 mental health counselors in your plan. That's parity, right? That medical and surgical is treated the same as behavioral health care. That's federal law. And on a state level, we have state regulations that enforce the federal law and the state law. In practice, December of 2023, the New York State Attorney General put out a report and indicated that 86% of listed in-network providers were actually inaccurate. So we deem this a ghost network. What this means is that if you called your health insurance plan and said, I need a mental health counselor, and they sent you a list of 100 mental health counselors that they said were in their network, right? It's their network provider directory. 86 out of 100 of those providers are not accurately in network. That's insane. Imagine going down the list, and maybe you've experienced this before, of being like, I just need counseling. Like, I'm in a low place in life. Maybe someone close to me has died or something. I just need to speak with somebody. You call your health insurance plan, they send you a list, and 86% of the people you call can't take that. And your health insurance plan is like, sorry, Charlie, this is who we have. You can't find anybody. Tough luck. As a result, people end up going out of network, and that means they pay out of pocket. So I called 86 people, nobody could take me, but I found this one person who said they had an opening, but they're not in network. They charge $150 a session. So in order to get the help I need, I'm going to pay $150 a session. And maybe my health insurance will reimburse me for some of it for out of network, but probably not. Ultimately, people end up not going to get the help that they need because they can't afford it. Breaking news. like news that I found out Wednesday, I want to say. No, yesterday morning. New York State employees being represented by their employee union have sued multiple insurance companies for ghost networks. Right. So they brought a class action lawsuit against two insurance companies, Elevance and Carillon, saying like the law says you're supposed to have an adequate and accurate provider directory, and you clearly do not. So we'll see what comes of this, but generally speaking, New York State, in fact, I've got other slides on this, but has been successful in suing insurance companies on behalf of not providing enough access to behavioral health services. So again, this is a barrier within. These are all different news headlines around ghost networks, inaccurate network from providers. So a former Cigna executive on a ProPublica webinar, this is what he said. The way to look at mental health care from an insurance perspective is this. I don't want to attract those people to my plan. I'm never going to make money on them. So one way to get rid of those people is to not have a great network. If you're like, I'm looking for a health insurance plan, I'm going to enroll in Cigna, and then you look at Cigna's health insurance or their in-network providers and you go, geez, there's just nobody there. Nobody to provide services. I need to find a different insurance provider because everybody in my area goes with Blue Cross Blue Shield. I don't know. Right. So ultimately, that's on purpose. Their provider network is crappy on purpose to drive you away, because ultimately mental health and substance use disorder care doesn't make them money. People who have heart surgery, they go in, they have their triple bypass, that the insurance pays for the surgery, it pays for a certain amount of rehab, right? And then it's over, right? Then the person has recovered from their heart issue, and that's that. But mental health is much more complex than that, right? You're dealing with complex trauma, you're dealing with severe depression, you're dealing with episodes of psychosis. Like, you're working with somebody for a long time to try to get them to a place of health. It's not as prescriptive as the health insurance is going to stop paying for coverage for this because the episode is taken care of. It just takes a lot longer. So health insurance plans don't want to cover it. So they create a lot of barriers because they want to keep your money. The next topic we're going to talk about is provider reimbursement. I mentioned the council. We represent 160 different providers around the state. So we hear a lot of these issues on a day-to-day basis, but low reimbursement. So I already kind of hinted at this, that health insurance plans underpay for the services that are being provided. They negotiate payments to providers through contracts. So it's not like it's not like this isn't a two-party system here, but health insurance plans typically have the power because they have the clients, they have the clientele. So especially if you're a small practice or an independent practitioner within this behavioral healthcare space, you're at the whim of what the health insurance plan is willing to pay you. And so therapists earn about $98 on average for a 45-minute session, but an out-of-network therapist can charge about $200 for a 45-minute session. It might seem like a lot of money, but again, I've tried to make the case here that clinicians, psychiatrists, psychologists, like these people have doctorate degrees. Licensed clinical social workers have to spend years of clinical supervision to get to the degree, to get a 2-year master's degree. Like, it's a lot. Physicians generally are reimbursed at 20% more for the same service. Again, so there's a there's disparity between how health insurance plans treat mental health practitioners compared to medical or surgical. Late reimbursement. So when a provider submits a claim to the insurance plan to receive reimbursement for services, the health insurance plan goes through all sorts of ways to delay that, because the longer that they can sit on the money that they have from you, the more they can generate revenue off of that money before they then have to pay that money off. So it can be delayed by months, by years. The service has already been provided, right? And they're just trying to get reimbursed for a service that they've provided. But the health insurance plan makes it very difficult, oftentimes, to receive that reimbursement. And so any billing mistake, just bank on the fact that, oh, it's going to take forever to get done. What we hear all the time, and I have this on a later slide, but I don't know what slide it's on, so I'll reference it again. But health insurance plans go through the process of just laying off all of the people who are there to help providers. So if you have a billing error and you get an automatic kickback from the health insurance plan and you're not sure what happened, and you go to call your rep, your health insurance plan rep, oh, they don't, like, we don't even have a plan rep department anymore. We've laid them all off. So there's nobody to call anymore. There's nobody to talk to. They're just trying to make it as difficult as possible. So ultimately, the result is providers just don't work with health insurance plans. So if you're saying, well, there's nobody in network with my health insurance plan, that's true. The health insurance plan has made it as difficult as possible to be a participating provider in network. And then subsequently, especially for smaller practices, it's like, it's not worth it. It's not worth the time or the energy or the effort, because I'm not getting reimbursed. It's coming super late. I'm not getting the price that I need for my business to survive. So there's all sorts of issues that come with reimbursement. So let's talk a little bit more about it, specifically as it relates to Medicaid managed care. So there have been multiple reports of non-compliance with federal law and regulations. And MAPIA there is the Federal Parity Law. It stands for, let's see if I can remember it off the top of my head, Mental Health Parity and Addiction Equity Act. I got it. Didn't even have to look at my notes. So Medicaid managed care is, if you're not familiar, and maybe many of you already are, but essentially we said, we're going to pay our Medicaid dollars to a Medicaid managed care agency, a health plan, and they're going to help ensure that the people who are enrolled in their health plan under Medicaid aren't overutilizing emergency room services unnecessarily, using, the highest level of services. We want to make sure that they're seeing primary care physicians. We want to make sure they're seeing licensed mental health counselors. Like, that's the idea behind it. But again, even within the publicly funded space, the parity of reimbursement, are you reimbursing at the right rates, and or network adequacy, do you have enough people in network? They're still not following federal and state law. My agency, the New York State Council, filed over 20 Freedom of Information Law requests with the state, because providers were essentially saying, like, A, we're being under reimbursed, B, we're not being reimbursed for services, and C, like, we know how much the state is giving to a managed care organization for behavioral health. Like, we have a prescribed amount of money that is supposed to flow from an MCO, managed care organization, through on behalf of behavioral health. And so that money wasn't coming through. And so the council went and filed these FOILs, and essentially the state went in and did an audit of the MCOs and found $220 million unspent that the MCOs were just sitting on, that they should have been paying out on behalf of their folks enrolled in their plan. So again, they're just sitting on taxpayer dollars, earning money off taxpayer dollars, not paying it out. They had to return $220 million to the state, which is then reinvested in behavioral health care. 45 citations in 2021 alone around inappropriate claim denials and non-payment. Again, this is just Medicaid managed care. Commercial plans delay payments to patients and providers for prepayment review. So I wrote a whole article about this, but what is becoming more common practice is that someone will go to a therapist for an issue and they'll get treatment. They'll turn it around. The therapist will say, thank you very much. You owe $100 for the session, and then your insurance is going to reimburse you, the consumer. Okay, so you pay $100. The therapist has been paid. The therapist submits the claim to the health insurance plan. The health insurance plan comes back to the therapist and says, we're not going to reimburse the consumer until we've reviewed all of the case notes, all of the medical necessity criteria. We want to know why that person was in therapy, if you provided the right kind of therapy. Otherwise, we're not paying it. That's called a prepayment review. And so the therapist in that situation has already been paid. I got my $100 for my session, but I'm going to now do all this extra work, including sharing private notes, and you don't want to violate HIPAA. And so you're redacting some things and you're proving that the work that you've already completed should be paid back to the consumer, right? This is a problem. Delays the payments for up to 9 weeks at a time. I mean, like, if you spend $100 per session once a week and then you didn't get reimbursed for that for 9 weeks per session, you probably would stop going. So again, commercial plans notorious for prepayment review. There have been multiple, associations. The American Psychological Association just wrote a very stern letter to Optum, which is Blue Cross Blue Shield's behavioral health arm, around prepayment review of its members and the disparity it's using in prepayment review versus medical and surgical. Again, they're just trying to make it more difficult. They're trying to drive people away from there. And so here's my bullet on closing provider rep and customer service rep lines so no answers can be provided on denials. My inbox sees a lot of these on a weekly basis. Anybody know who I can contact at Blue Cross Blue Shield about this denial code? I've done everything they've asked me to do electronically. They just make it as difficult as possible to resolve complaints. Here's some more news to show that I don't make these things up. These are all coming from sources. Also, all my sources are listed at the end here. I've got 2 slides full of sources. So if you're interested in doing a little bit more research, lots out there. Go ahead, Amy.
I was going to tell you, I've been dropping some links into as you're talking, so I'm trying to be helpful, and that way if people save the chat. But yeah, this is great. Really great information.
Awesome. Thank you. I see that the chat has like 8 things in it. I'm not looking at it.
Don't worry about it.
Really hard to stay on topic.
I got it.
If anybody has ever heard me speak before, they know that I am long-winded. I should start a podcast just so I can get all the words out of my mouth on a daily basis, so my wife doesn't have to listen to me at the end of the day. But yeah, so feel free to interrupt me, Amy, if there's any questions coming in that I need to give attention to. So I told you we were going to talk a little bit more about parity specifically. Essentially, people with behavioral health conditions, mental health, substance use disorder, they have more difficulty getting treatment and services when compared to individuals seeking medical care. And so the Mental Health Parity and Addictions Equity Act, that was passed in 2008. Then it was strengthened in 2014. We've had regulations come out of the CMS, which regulates that law in 2016. And then again in 2024, they just did some more to strengthen this law around parity. Again, if you have 100 primary care physicians that are in network, that's someone who is a part of your plan, can go see 100 different primary care physicians, and you need to have 100 behavioral health clinicians as well. That's parity. Coverage may also not be more restrictive for behavioral health than it is for medical or surgical. This is the last line here, meaning that if you need prior authorization, if you need permission from your insurance plan to see your mental health counselor, but you don't need permission to go see your primary care physician, you can just make an appointment. That's disparity, right? That's not how it should be. That's more restrictive because you've had to go through an extra step getting permission from your health insurance plan before you see your mental health clinician. So That's not allowed to be more restrictive in that way. The second line there, federal and state law requires insurance benefits for behavioral health to be equal to the coverage of other types of care, meaning you can't have like a $3,000 maximum for behavioral health services, but a $10,000 maximum for medical or surgical services, right? Parity means that you have equal maximum allowances on each side. So let's talk about how health insurance plans violate the parity law, because they do it all the time. Medical necessity. So an example of a parity violation in medical necessity is that they have more intensive monitoring of symptoms for behavioral health. So medical necessity is just like common health insurance practice, right? We want to make sure that if someone is going to the doctor, that they're going to the doctor out of medical necessity and not because they feel like it or for whatever reason, right? So medical necessity reviews happen on both sides of the coin, medical and surgical and behavioral health. The reality of our situation is that there's a lot more scrutiny around behavioral health than there is around medical or surgical as it relates to medical necessity. So that whole idea of prepayment review that I talked about on an earlier slide, of needing to see all the case notes to ensure medical necessity, is a way of disparity in the medical necessity criteria, because they're not doing prepayment reviews on the medical and surgical side at the same rate that they're doing it on behavioral health. It's also much more difficult to determine medical necessity, especially when you're treating somebody with depression as opposed to a heart failure, right? So if you're looking at a case note written by a clinician as a health insurance plan going like, this person doesn't seem that depressed anymore. Are you sure it's medically necessary for them to continue to get counseling? Like, they're not in the session. They don't know these people. These people are just numbers on an Excel spreadsheet to them, right? But they're looking at a case note, trying to find any way they can to essentially say, we're not going to continue to pay for services anymore. They very often do this more critically of behavioral health services than they do for medical or surgical. Cost sharing. So again, you're not allowed to have a higher copay to go see a mental health counselor. It can't be $40 to go see your mental health counselor out of pocket and only $20 to go see your primary care physician, right? Like we all experience copays. Like if you show up to the doctor, pay $20, okay, whatever, great. But if you're paying $40 for your mental health counselor and only $20 for your primary care physician, that's not right. You as the consumer probably don't realize that's not right, that that's against the law. The reason that health insurance plans can continue to get away with parity violations is because the amount of regulatory oversight and compliance enforcement is limited, both at the state and federal level. Just costs a lot of money and resources. And, you know, a perfect example is that Ghost Network report that came out from the Attorney General in 2023. And it wasn't until the end of April or the beginning of May of 2025 that litigation was brought, right? That's the enforcement arm. That's New York State enforcing network adequacy laws and regulations through litigation. Again, that just takes a long time to do, costs a lot of money, takes a lot of people's time and effort to pull that together. And that's why health insurance plans can continue to get away with it. Prior authorization. Requiring permission from a plan to get services reimbursed is what prior authorization is. Typically, that the responsibility for prior authorization falls on the provider, not on the care recipient. And so if a plan is saying you need prior authorization to, you know, what actually a good parity example would be like this. Your plan requires prior authorization for inpatient services on both the medical and surgical and the behavioral health spectrum, prior authorization for both. But in reality, when you go into medical and surgical, you've gotten your prior authorization. The plan will reimburse 7 days while you get the prior authorization done. Plan's going to reimburse 7 days while you're in medical and surgical. But if you show up to inpatient substance use disorder, they're only going to reimburse for 1 day unless a service plan is submitted within 24 hours from the provider, right? And so it requires the amount of work they're requiring from a behavioral health provider is significantly more than medical and surgical, especially based on the amount of time they're willing to give leeway around this stuff. It's a parity violation. We see this every year. There have been multiple national reports in New York State, but improper denials of care happen at much higher rates in behavioral health. So part of the work that CHAMP does is we help folks appeal denials of care. So if you've gone to your mental health counselor, your insurance plan says we don't think it was medically necessary, so we're not paying for it, so you have to pay for it. Then the provider's billing you directly and saying, hey, sorry, you owe me $250 for every session for the last 3 months because the insurance plan decided that it wasn't medically necessary for whatever reason. You're kind of stuck in the lurch. What do I do? And they give you a whole, 10 pages of what you can do with a denial. But like now you're reading legalese and you need a lawyer or you need to figure out what to do. Ultimately, what we see, the trend is that if you appeal a denial of a behavioral health service, the denial gets overturned at a way higher rate than denials in medical and surgical, right? And so what that means is that they're just denying behavioral health stuff at a higher rate, even if it's wrong, because they don't want to pay for it. There was a report that came out from the Kaiser Family Foundation that indicated that about 1% of all denials actually get appealed. So health insurance plans know that if they deny, even if it's incorrectly, the likelihood that someone's going to push back against them, very low. So denials is how health insurance plans make money. If you got the service and you had to pay for the service and they didn't, they got to keep your money or the public's money in Medicaid case, and the service was still provided. So they get to keep the money. That's how denials work. It's where the majority of their profits come from. And so again, it happens at a much higher rate in behavioral health than it does in medical. Drug treatment design, prescription design, different standards for behavioral health compared to medical or surgical. So a parity violation might look like your health insurance plan has methadone. You can get methadone for an injury, but you can't get methadone for an opioid addiction, right? So they're both on the formulary, but you can't get one for behavioral health and you can get one for medical surgical. That would be a parity violation. So parity enforcement, again, I talked a little bit about this on the previous slide, just that enforcement comes few and far between, but the state issued managed care organizations 95 citations for noncompliance from 2018 to 2020. A 2022 survey of MCO documents found that they repeatedly failed to demonstrate compliance. I don't think that this is a super surprise to anybody who's dealt with health insurance and found it to be difficult. Commercial plans. In 2021, the Department of Financial Services issued penalties and restitutions of over $3.1 million to these 3 insurance companies. These 2 federal agencies cited 25 MAPIA violations, that's the federal parity law, and fielded 148 complaints in 2022. So again, it's just the enforcement, the oversight of the health insurance plans is inadequate. Let's just put it that way. One reason why, and this will kind of irk some of you, it certainly does me, is that even when we release new regulations, so we just released new network adequacy regulations in New York State. Those regulations come online July 1st of 2025, and they essentially say health insurance plans have to have adequate networks for behavioral health. Like you have to update your plan documents. You have to inform people. They have to be able to find providers on your website. They have to be able to provide services within 10 days, right? This all falls on the health insurance plan, right? That's the new network adequacy regulation that just came out. Enforcement and compliance with the regulation falls on the health insurance plan itself to self-report if they're not in compliance. Like it's like when we were all in school and we took a quiz and then the teacher had us grade our own quiz. Not saying that I ever did it, but the guy sitting next to me would like erase his answer and then fill it in right. I never did it, but somebody else for sure did. That's what we're asking these health insurance plans to do, right? Is to self-regulate and to self-report. Hey, I'm not in compliance. It's great to have the regulation on the books, and it's great to have a standard by which they should be held. It allows litigation down the road, right? Like it allows all kinds of investigate. Like, but if it's, hey guys, you got to like let us know if you're not doing it right. You gotta hire somebody internally to look at your stuff and make sure it's with it. It's just not going to happen. Sorry to say. That's the jaded part of me. Sorry, everybody. Step therapy. When a health plan implements a step therapy protocol, it means that the care recipient is needing to have a lower cost pre-approved medication instead of the one prescribed by their physician. So again, we're talking about barriers that health insurance creates to getting access to the care that you need. You know, the way that they build out what's called their formulary is broken. And if you've ever heard of, if you've like tuned into C-SPAN, not that you would, but if you've tuned into C-SPAN and you've heard Bernie Sanders or literally any senator, I think they all talk about this, say, we need to reform the pharmacy benefit manager system in our healthcare system. This is what they're talking about. So the way that this works is that, let me make sure it's not on my, okay. The way that this works is that a health insurance plan will have a list of prescription drugs that they will cover. That list is tiered. So step 1, step 2, step 3, or tier 1, tier 2, tier 3. So typically tier 3 drugs are the most expensive drugs. Tier 1 are the generic drugs, the least expensive drugs. So when someone gets a prescription for, let's say, an antidepressant from their psychologist or psychiatrist, I should say, and they go to fill it at the pharmacy, and the pharmacy says, your health insurance isn't going to cover that. They're only going to cover the generic, or they're going to cover this other antidepressant. Okay. So your health insurance plan said you have to try this cheaper one first. And if it doesn't work, then you go to step 2. And we got other drugs on step 2 that you'll have access to that we'll reimburse for. But you have to fail on step 1 first. So that essentially means, like, I'm struggling with depression. I've been prescribed an antidepressant based on the evaluation of my psychiatrist, but my health insurance plan won't let me access it. I have to try something else. I have to stay depressed while I'm taking a different antidepressant that's not working. Then I have to prove to the health insurance plan that it's not working. The way that these formularies, the formulary is the list of covered drugs, get developed is through these pharmacy benefit managers. So the PBMs, as they're known as, have relationships with the pharmaceutical companies that make the drugs. The pharmaceutical companies give kickbacks to the financial kickbacks to the PBM who develops the formulary for the health insurance plan. They'll say, we'll give you a rebate, PBM. We'll give you a saving, a discount, essentially, on the drug. You can charge $1,000 for the drug at the consumer level, but you only paid $500 for the drug because you got a rebate from the manufacturer. PBMs, there's like no oversight, federally or state, of PBMs. They do this. And so essentially, if you want to know how a formulary is made, it is cheapest drugs and then however much money they were paid to put the drug on tier 1 or tier 2. Does that make sense? So it's essentially like pay to play. So why step therapy? And so what's interesting about this first left-hand side that I'm going to talk to you about here is that I'm not making this up. This is like from their advocacy at the state level around, like, this New York State has tried to regulate step therapy through law. And so this is what their plans have said in response. They say, step therapy protects care recipients from harmful care. Their psychiatrist doesn't know them as well as the health insurance plan. They prescribe them that drug, but we don't want them to be harmed by that drug. We want them to try this safe and drug that we know about and are willing to pay for. It also promotes the use of cost-effective medications, right? We don't want to pay for the name brand ones. We don't want the pharmaceutical companies buying off the prescribers, your doctors, and having them prescribe expensive drugs. We want to make sure that everybody's using low-cost medications because that keeps the cost of health insurance down. And then they say provides leverage in negotiating drug prices with pharmaceutical companies for their formulary development. Remember, that's their list of drugs that are covered, because, you know, ultimately they can say, oh, you know, you give us a $500 rebate per pill on this antidepressant and we'll put you on step 1 of our formulary, right? That's the leverage that they have. So does step therapy work? Does it protect care recipients from harmful care? What does the research say? Well, research says that 68% of care recipients who are put on step therapy stop taking their medication altogether. We've seen a 4.7% increase in outpatient visits as a result of step therapy, a 17% increase in inpatient admissions as a result of step therapy, a 37% increase in emergency room visits as a result of not having access to your medication prescribed. Also, the research has found that only 1/3 of the formularies aligned with clinical guidelines, right? So the insurance plan says, like, our formularies are built based on the best clinical evidence around how to treat certain symptoms of depression or whatever. But then you go and actually look at their formulary and say, well, the research actually says that that's not clinically aligned with the guidelines of best practice or what the research says at all about those drugs. Those are just the cheapest drugs. So the results mean higher profits for plans because they're not covering the prescriptions that are being prescribed. The rebates from the pharmaceutical companies are getting put in the pocket of the health insurance plan. There's significant negative health effects on consumers, and ultimately they lead to higher overall medical costs because folks have to go to the emergency room because they're dealing with whatever it was that they were trying to take care of that is no longer being covered by their insurance. I'm almost done, I promise. NQTLs, this is I told you, it's just common practice across both behavioral health and physical health. But a non-quantitative treatment limitation are non-numerical limits on the scope or duration of benefits for treatment, like pre-authorization requirements. So here is a list of NQTLs that plans use: medical necessity, we've talked about, formulary design, network tier design, provider participation standards, charge determination, step therapy, exclusions based on failure to complete treatment, restrictions regarding the scope or duration of benefits that they'll provide. So they're allowed to put restrictions on your access to care in each of these 8 different levels. These are all considered NQTLs. Oftentimes, the way that we're looking at them from CHAMP's perspective or is from a parity perspective, because NQTLs exist both on the medical and surgical and behavioral health side. But are these things more stringently enforced or more restrictive? Are these NQTLs more restrictive on the behavioral health side than they are on the medical and surgical side? We often find that they are. But these are all ways that are allowed for your health insurance plan to create barriers to you to accessing care. I'm not going to go into each one of them in depth because we don't have time for that. But the point is to show you that really every step along the way, your health insurance is not necessarily your friend. It is oftentimes the antithesis of your friend or your foe, some might say. I'm going to spend the next few minutes just telling you about CHAMP, and then we'll have about 10 minutes or so for questions if you have them. CHAMP is the Community Health Access to Addiction and Mental Health Care Project in New York State. We are the statewide ombudsman program. We help patients and providers navigate the health insurance barriers that folks face when trying to access behavioral health services. So an ombudsman program, if you're not familiar, we essentially are an advocate on behalf of usually people who are experiencing these barriers. An individual might call our helpline, which I'll have on the screen shortly. We're not an information line. You're not going to call us and get some information about health insurance. You're going to call us and we're going to work with you from the first time you call until your issue is resolved. So if you've gotten a denial, hey, I went and got counseling and now I got a bill and I can't pay it, or I don't want it, I don't feel like I should pay it. You call CHAMP, we're going to help you appeal the denial. We're going to help you fill out that form and request all the paperwork you need from your plan. We're going to follow up with you to see where that is. We're going to follow up with your insurance plan to see if it's being processed. Like, that's the service of the Ombuds program. It's not an information line. Hopefully that's helpful. It's a joint project between OASIS and OMH. I mentioned that at the beginning. CHAMP is a network of 13 agencies. So the work that CHAMP is, like CHAMP as an entity, is actually 13 agencies. We're 9 community-based organizations and 4 specialist agencies. All of our services are free and confidential. We serve all languages. So if you call our helpline, the helpline specialist can speak Spanish or English, and then we use a translation service for all other languages. We deal with all types of insurance: Medicaid, Medicare, TRICARE if you're in the military, the Essential Plan, qualified health plans, Child Health Plus, all commercial plans. So if you have like work-sponsored plan, and then for folks who have no insurance at all, CHAMP can also help someone enroll in health insurance. So you're having a barrier to accessing care because you don't have insurance and can't pay for it. CHAMP can help you enroll. We serve all of New York State. So here are the 9 community-based organizations. They are the colorful ones, and their areas of the state that they serve are highlighted on the map here. The 4 specialist agencies I'm going to highlight for you. The Legal Action Center deals with a lot of our parity stuff. So when health insurance plans are violating parity law, LAC does a lot to help file reports and complaints. Reports go to the relevant state agency, complaints go to the Attorney General's office. They are lawyers who are helping deal with these issues. It's nice to have a lawyer in your corner in a free service that's being provided to you. The Medicare Rights Center, they're a nationwide organization that helps folks with Medicare issues, and they have a New York State chapter. And at their New York State chapter, they have a specialist who deals with complex Medicare issues. And if you've had to deal with Medicare, maybe as a caregiver or something like that, you'll know that there are a lot of complexities to Medicare that we could spend 3 different presentations just talking about the complexities around Medicare. The New York State Council, the organization I work for, is a part of the network. And then Community Service Society of New York. They operate the main helpline. They contract out to all of the specialist agencies and all of the community-based organizations. They take the lead as the center of kind of the model that we are. So how does CHAMP help? If you call up CHAMP and you're looking for help, here's what we do. We can do a benefits review. So what behavioral health benefits are covered? How do you access them? If you've ever gotten a health insurance packet in the mail, it's this thick, you have no idea what everything in it says. I get them once a year. I work in health insurance now, right? Like, this is what I do for a living. I get those things in my mail and I'm like, I'm going to read mine this year. I'm definitely reading it. I feel like I should know. And then it sits up here on my desk in the pile of all the other things that I promised myself I'm going to read. And then 6 months go by and I get a new one in the mail and I never read the old one. And I'm like, dang it. So if that's me and I do this for a living, I'm assuming nobody else in the whole universe has read their benefits packet from their health insurance provider. And so what our specialists are trained to do is know where to look in your benefits package, what's covered, what's not covered. You know, if you've received a denial, is it specifically stated in your benefits review packet that shouldn't be covered, or is this done in error? Things like that. We can help folks find in-network providers and provide referrals. So again, if you're looking down the list of providers who are supposedly in network, can't find anybody, we'll help you find someone in network. Again, with the new network adequacy standards that are coming into play, there are also new requirements that, again, a general consumer is not going to know. This is where CHAMP can help. Health insurance plans come July 1st are going to be required to provide in-network behavioral health services within 10 days of request. So this is where that question around wait lists comes into play, right? So if you call somebody and they say, yeah, I'm in network, I'll see you in 3 months, that doesn't fly anymore in New York State. You can call your health insurance plan and say, I need to see somebody for my mental health condition who's in network. Your health insurance plan will then have 3 days to send you a list of in-network people who can see you within 10 days. If they can't do that, if they don't provide it within 3 days, or there's nobody in network who can see you within the allotted time frame, your health insurance plan is mandated to cover out-of-network services for you at no additional cost to you and at the same rate that they would pay someone who was in network for the provider. So you could go to a provider who's out of network and say, can you see me within 10 days? They say yes. All right, great. My insurance is going to pay you because they didn't have anybody in network. So like, again, that's something that a consumer, now all 23 of you on this call know that, but generally a consumer is not going to know that. I'm sure their health insurance plan will be mandated to inform them of that via some piece of mail that no one's going to read, but that's how it is now. So again, call CHAMP, will help you through navigate all of the idiosyncrasies of all of this. We help folks get approvals for prior authorization, out of network, additional services. I kind of just spoke to that. Appeals, we assist clients in appealing denials of services and medications. Again, this is kind of the bread and butter. We do provide a lot of information, but like the big bulk of work is like, you got a denial in the mail, you don't know what to do with it, we'll help you appeal it. Again, it's not an information line. You're not going to call and say, what do I do? You're going to call and a case assistant is going to say, let me help you file an appeal. Okay, it's a really helpful service. And then we also identify parity and legal violations, file complaints and reports to New York State. This is our helpline. It's open Monday through Wednesday from 9 to 7 and Thursday and Friday from 9 to 4. We haven't gotten up to the coalition standard of 24/7 helpline. Great job, guys. I think you still have that helpline going, but you can reach out to us during those hours. We also just developed a brand new website, champny.org, where if you are a person that just wants more information about how to appeal a denial, we've got fact sheets up there about how to do that, those types of things. And again, you can call our helpline. I'll just say right now that the helpline is a great resource. It goes to CSS, Community Service Society, and it'll take you to a phone tree. So if you're trying to find services, you know, CHAMP services, you're looking for behavioral health, right? Health insurance barriers. But CSS also operates health insurance navigators. So if you're actually just looking to enroll in health insurance, you navigate to them. If you have a medical or surgical health insurance barrier, they also operate the Ombuds program for that. So the same helpline number can get you to multiple places, which is really great and helpful, because a lot of times folks go, wow, it's really great that the state has that for behavioral health. What about the dentist? You know, what about the surgeon? Like, yeah, you can call the same helpline number here listed and get to over to community health advocates. summary of this presentation, and then I've got 15 minutes for questions. We talked about youth experiencing a crisis here in New York State. We talked about barriers to accessing the available care. We talked about how CHAMP can help folks. Here's me with my 2 children on Easter, so pretty recently. George is the older one. Harvey is the younger one. We just spent, however many, an hour and 15 minutes talking about health insurance. And so I always kind of figure it's nice to take a look at cute babies at the end of a presentation to lighten the mood, to get people in a talkative mood. So if you have questions, I'm certainly happy to take them from you all.
Thanks, Ryan. Does anyone have any questions?
I have a quick question.
Sure, go ahead.
Hi. So first off, thank you very much. I felt like this was super informative, and I took down a bunch of notes. So, I think that it's something that I'll find very helpful in the future. The one question I did have was at the very end, you mentioned that same phone number.
Yep.
We would be able to call it if there was any questions or issues, coverage issues regarding dental.
Yeah, they do. So Community Health Advocates deals with medical, surgical, health insurance issues. So yes, if you navigate through that same helpline over to Community Health Advocates, they'll deal with all of that stuff.
Okay, perfect. Thank you.
You're welcome.
Trying to see if there's anyone else. Pat, I think, had to jump up, but he said, so mental health professionals are not considered specialists. I know that I pay higher co-pays for specialists. So I think he's just trying to reiterate. Okay.
Right. Yeah, you should not be paying a higher copay to go see a mental health counselor than you are for a primary care physician. Those types of issues, again, even if you're like unsure. And I guess here's the other thing too. I think oftentimes what happens is, especially in the helping profession, right? It's like, oh, well, this is a great service for foster care families, or this is a great service for people on Medicaid or people who are underserved or whatever, right? But like the issue with health insurance barriers is that it impacts everybody who has health insurance. Poor people, rich people, like, you know what? Like we all have the same access problems. So, if Pat is over here saying like, oh, well, I think I have that problem. Like, yeah, Pat can have that problem too. Like I have that problem. Like my best friend, his dog died and he was like, dude, I need a counselor. I need a therapist real bad. Right. And it was like, yeah, man. And he's like, I can't find anybody who's in network. He has that problem too. Like it's not like, oh, this is underserved. It's everybody deals with these issues. These issues are going to affect anybody seeking services. So don't feel like, oh, this is going to be great for my client. It might be great for you. The number of times I've presented this to different groups and had the person who organized the presentation come up to me and be like, my 16-year-old daughter needs therapy and I've been trying to find her therapy and nobody in network and I pay $150 out of pocket. Like that kind of stuff. Again, with new network adequacy regulations coming online July 1st, like shouldn't have to happen anymore. But you don't know about it if you don't utilize CHAMP as a resource or listen to one of my presentations.
That's great. Ryan, are you also going to be in person at the conference?
I will be at the conference. Really looking forward to being there.
Great.
Happy to chat more about these issues. But I found that last year at the conference, I spent a ton of time talking to people about kinship care, which is super cool because I miss talking about kinship care. And a lot of people wanted to talk to me about kinship care. So if you see me, I'm the guy with the mustache. Although Pat has a mustache too, so don't confuse me and Pat. But but yeah, I'm happy to talk about these issues or kinship care or anything really.
So let me see. Someone has a question about the chat. I can certainly save the chat just shoot me a message and I can send it to you if you're looking for links. Also, this will be in the network, the communications team. If you're part of our conference community or your staff, this will be in our AFF-CNY network as soon as the communications team is able to have it uploaded. They're super busy now, but you'll have access to that. And I'll make sure I will save the chat right now.
Hey, Amy, can I jump in with a question? This is Chester.
Absolutely,
Now,
absolutely.
I was on a helpline call, so I had you guys muted. I couldn't hear. So if you've answered it already, I apologize. I was just really struck by that huge number of young people that, you know, the onset of whatever is 10, and they don't get around to getting any kind of help for it, and generally in 10 years.
Yeah.
How much of that is owed to parental inaction or the inaction of the adults? I'm sure there are a million reasons why, but what's like the main driver of that? Could it be
I don't know that I could speak to the main driver, because I think it's a collection of issues, right? So stigma certainly plays a large role in it. If someone, especially a parent, is like, nope, my kid's not struggling with that. Nope, I'm not getting them the help they need. It's tough it out, those kind of issues. But also on a young person's, there's stigma within the young person community as well, right? Like, I don't want people to think I'm weak. I don't want people to think I'm different. I don't want to, you know, be seen as like, oh, that person's crazy or whatever. Stigma plays a part in it. Certainly the access to services is part of it as well, because if you can't find somebody in network and you can't afford to see somebody out of network, you don't have access to the services that you need. Oftentimes these things might go unrecognized or undiagnosed. So if you're not in a space, most kids are in school, and school should be trained in identifying, you know, these types of issues. But if you're not in a space that does well to identify those children who are struggling, is another reason, right? I don't think it's like, this is the reason. I think it's all of these things play a contributing factor in why people aren't accessing care.
Yeah, and thank you. And another quick one. You talked about we can folks can call you for anything except general information. Could you just like own that a little bit more specific? So if somebody calls up and says, "Hey, what's a good insurance company?" They shouldn't call you for that, I guess, right?
They could call us for that. So I guess what I was trying to say is, like, we're more than just information. So if you're calling just expecting to, you know, talk to somebody and they'll talk you through like a couple of details about your how to appeal, and then you're on your own. I guess the point I was trying to make was, like, you can call us for general information. And a lot of what we do is like, people just need information. I don't understand what's covered or what should be covered or whatever. But what I guess the point I was trying to get across was that we're more than that. Like, you will be assigned a case assistant who is willing to be with you as much as they can be and as much as you want them to be. So that's the point I was trying to make. Sorry if it came off as confusing.
Issues all across the board, right? Like,
you got it.
I've been denied. They're telling me I'm not eligible anymore. All across the board.
Absolutely. And so, like, you know, those issues range from my Medicaid got dropped. I was incarcerated. It went to this, and now it's over to that. You know, I don't have access to my pharmacy because I've got restricted Medicaid. And there's a zillion billion issues that folks can have. That if it's a health insurance barrier, if it's health insurance related, and it's related to accessing behavioral health in some form or fashion, we'll deal with it.
Yeah, that's great. And also that's the substance abuse issue. So if someone has a substance abuse issue, I need help, they can talk to you about that?
Absolutely. We deal both in mental health and substance use disorder.
Cool. Thank you. Yeah, that was great.
Yeah.
It was very depressing. It was very depressing, but
I know. That's why I put the picture of the kids up at the end. Jeez.
Ryan, can I ask a question? You don't have any information on the types of treatment centers? Like, if somebody was asking you, how could we know, or do you know of a good treatment center for a youth or adolescent? Do you guys handle that sort of stuff?
All the time. So a lot of our CHAMP advocates, especially at the community-based organizations, are folks who have utilized the system themselves at one point in time. And we do a lot of referrals and a lot of connecting folks to resources like that all the time.
So if I have a family that's looking for a recommendation on a treatment center for their child, an RTC,
Yep.
that was being covered by private insurance, not Medicaid,
Mm-hmm.
then they call the CHAMPS helpline.
Yeah. I think, honestly, I guess I should say this generally. Even if you're unsure, like, is this a CHAMP issue or not a CHAMP issue? The one that you're referencing right now, definitely a CHAMP issue. Definitely give CHAMP a call. Even if you're not sure, we're not in the practice of answering the phone and going, oh, I can't help you with that. Sorry. And hanging up. We're a service that says, oh, this person needs XYZ. That's not within the scope of what I do, but I know of this service that can help you with that, or I can refer you over. And so the great part about the helpline is, like I was mentioning earlier, CSS has all these, I've only mentioned 3 of the different services they have, but they got a zillion. So if you call and it's not a specific CHAMP issue, we're not just going to say, sorry, Charlie, that's not what we deal with. Good luck. It's like, it's a warm handoff. It's like, oh, that's not quite a CHAMP issue, but here's the folks that can help you with that.
Okay, that's wonderful news. What about for adults? You do the same thing for adults or just
Yes.
children?
Nope, we serve everybody, all ages.
So if you're a family with a child who just turned 21 but is autistic and there's no more education or services provided for them in New York State, they can call you for help?
They can call us for help.
Thank you. You've been
You're-
very helpful. Thank
You're
you.
welcome. Certainly.